Dr. Marwa? Can you unmute maybe?
I asked her to unmute. Wait.
Okay. Marwa, can you hear us?
Oo. Pero electric, ay hindi pala electric na. Ito. Ay electric, Savage. Yun. Pakita ko kayo sa kanya. Na?
Dr. Marwa cannot hear you. Dr. Marwa? Dr. Marwa, we can see the slide, but we cannot hear.
You're able to hear me because I cannot hear anyone.
We can hear you now. Can you hear
Now?
me?
Yes, I can hear you, Dr. Yassine.
Okay. So thank you everyone for attending the Saudi Critical Care Trials Group. We're very excited on having a study proposal for a multi-center study presented today. The idea from this discussion is to get input from the group and see what could be the next step for this important project, and seek the interest of different sites in this study. So I really appreciate Dr. Marwa Amir, who put together this proposal for adjunct ketamine compared to usual care in mechanically ventilated patient, a proposal for an international randomized active controlled multi-center trial. So Dr. Marwa, floor is yours.
Okay. Okay, you're able to hear me and see my slides?
Can hear you, but the slides are gone.
Oh, okay.
And if you can come closer to the microphone, it would be better. Yes, this is good.
Okay, and able to hear me now?
Yes, thank you.
Okay, thank you, Dr. Yassine, for the opportunity to present today. Good evening, everyone. Today I'll be discussing the investigators' ongoing proposal for ketamine to usual care in mechanically ventilated critically ill patients. It's a proposal for international randomized active control multi-center trial. To start, I have nothing to disclose except for being a PI for the ketamine pilot clinical trial. And at any point, please let me know if my voice is unclear at any point during the presentation. Okay. Firstly, we'll briefly discuss a background of ketamine and its clinical utility in ICU. Then I'll be discussing a proposed ketamine research program exploring the use of ketamine in ICU patients, just to have a sense what have been done and what are the plan moving forward. During this presentation, we'll be covering the survey, pilot RCT, and the systematic review and meta-analysis, and what then this will be followed by the development of rapid practice guideline based on the available evidence, and then the proposed international randomized active control multi-center trial to evaluate the impact of ketamine on clinical outcome, and if there is any clinically meaningful difference between ketamine and non-ketamine sedatives or standard of care. Okay. So we'll start first with the background for the ketamine or for the sedation, which if we look at the slides, which nicely summarize the evolution of sedation in intensive care unit. As we all know, many landmark trials have contributed to the development of this field. With the implementation of PADIS guideline or PADIS tools, sedation protocol, and early mobilization, as well as the SPT and the SAT, this multidisciplinary approach have been utilized to ensure the patients in ICU are calm, cooperative, comfortable, and have a smoother journey towards the recovery. As you can see here in the slides, in early 2000s, the concept of analgo sedation was introduced in the ICU using fentanyl as a preferred opioid. All alternative medication like remifentanil, hydromorphone, or morphine. However, the opioids usually have limitations such as tolerance, hyperalgesia, and risk of withdrawal or persistence use. Additionally, the current opioid crisis in developed country emphasizes the need to limit the overprescribing for the opioids, and that's why nowadays they're considering the alternative options or opioid-sparing alternative strategies, such as regional blocks, NSAIDs, or acetaminophen. Ketamine is one of them. However, if the analgesic sedations alone doesn't meet the sedation goal, then traditional sedatives should be used, like propofol is the most commonly used one as a first-line agents because of the quicker onset and a quick offset and titrability. Alternative to propofol would be dexmedetomidine or benzodiazepine. It's just depending on the patient condition. We'll start with the ketamine, which is the focus of this presentation. It's a phencyclidine analog synthesized in 1960 as a synthetic agent and has less psychotropic effect than the PCP, available in US and Saudi Arabia as a control medications, and acts as dissociative anesthetic analgesic agents. It produces sedation at cataleptic states where the patient eyes can remain open sometimes, but sensory depressed. Initially was used in pre-hospital analgesia and battlefield. Ketamine has a variety of pharmacological effects at different receptors. It's fairly complex pharmacology. It has a sympathomimetic effects, acts as a catecholamine reuptake inhibitors. It also has a negative inotropic effect, as well as a bronchodilators, which tend to preserve the respiratory function, especially at the sub-anesthetic dose. However, it has psychomimetic effect, which can be reduced by a slow IV infusion or given in combination with other medication like a propofol or benzodiazepine. Okay. Ketamine has shown a promise as an alternative analgesic sedations in hemodynamically unstable patient and offering also a favorable analgesic property with a fewer side effects than the opioids. And also, as we learned from the COVID pandemic, many centers now, when they experience a high surge of COVID patients, they experience a significant drug shortages, which forcing the clinician to use alternative agents. One of them was ketamine. Ketamine can be used as in acute pain management, analgesic, status epilepticus, status asthmaticus, or acute agitation, and alcohol withdrawal as well. In terms of the guideline, in the PADIS guideline, mainly ketamine is mentioned for the pain as a conditional recommendation with very low quality of evidence, and has been used as part of enhanced recovery after surgery or post-surgical adult patient, but no recommendation for ketamine use as sedatives in ICU. So just to summarize here the potential advantage of ketamine, in short, it appears to be feasible and alternative in patients with respiratory and hemodynamic instability, because it usually doesn't affect the blood pressures or heart rate compared to propofol or dexmedetomidine. As well as it acts as a bronchodilator and maintain respiratory drive and airway refluxes, and increases the blood pressure and minimum effect on bowel motility, which all of these will help to limit the significant amount of opioid and its associated risk, like the ALS or withdrawal and respiratory depressions, especially in non-intubated patients, as well as the development of the paradoxical hypersensitivity from the opioid or opioid-induced hyperanalgesia. So in short, ketamine appears to be safe in patient in neuro patients as well, in TBI patients, which we're gonna discuss in the next few slides. And however, it should be, literature or some evidence shows should be avoided in patients with cardiogenic shock, heart failure, or a patient with those psychomimetic history or psychiatric history and pulmonary hypertension. Okay, let's move on now to the proposed ketamine research program, starting with the survey that was conducted to understand the current utilizations for the ketamine rate and dosing of the ketamine across various ICU. So this is a 2022 online survey developed by a member of the SCCM, queried for the self-reported practice regarding ketamine, using the, and also they are question for the potential barriers in acute and critically ill patients. So most respondents reported never or infrequently using ketamine. Provincially, they using, if it's going to be used, they're gonna use it for continuous IV infusion for analgesia or a sedation. For analgesia, 55% of the respondents, and for sedation, 61% of the respondents. Responses were mixed, of course, across the dosing range and duration. The most common barriers reported by the responder for using the ketamine were the adverse effect in 42%. Other practitioners not routinely using the medications because they are not familiar with the medication doses or duration. Like a lack of evidence, lack of familiarity, 33%, and hospital institution policy guiding the indication for use. Moving to the second step for the ketamine, which is the pilot visibility study, and the main key questions or main key pick-up questions in this pilot study was in mechanical ventilated critically ill patient, what is the visibility of a larger RCT testing the effect of ketamine as adjunct analgesic compared to the standard of care alone as a control group? Okay, we did this pilot active controlled open label RCT at medical, surgical, and transplant ICU. It's registered in clinicaltrial.gov and the current control trials and the FDA. They included the adult, we included adult patients who are intubated within 24 hours, randomized into 1-to-1 ratio to ketamine arm or the standard of care group as a control group. We used a fixed rate of the infusion for ketamine, 1 to 2 mics per kg per minute. Since this was a pilot feasibility trial, there was no further intervention after 48 hours. So we only followed the intervention or the study medications for 48 hours. However, we follow up the patient for clinical outcome and adverse effect up to day 28. The target RAS was left to the attending physician, and the titration of other sedatives was done by the nurse according to the target RAS set by the treating physicians. And other aspect of care in both group, including SAT or SPT, mobilization, was left also to the treating physicians. The main primary outcome here was the visibility outcome, which is the consent rate, the patient recruitment, protocol adherence. We also measured the clinically relevant outcome. However, this was exploratory outcome. Looking at the trial flowchart, we screened a total of 437 patients from September 2019 through November 2020, and about 83 patients were included, 43 in the control arm and 40 in the ketamine, and about 352 were excluded. 88 didn't meet the inclusion criteria, and 247 were excluded because of the reason listed here in the slides. Mainly, it's because of the patient. Usually, they don't require an intubation, or they expected to require a mechanical ventilation less than 24 hours. Inclusion and exclusion criteria is detailed here. Mainly the patient excluded for if we have any patient has a tracheostomy at a baseline or intellectual disability that preclude delirium assessment, transferred from outside hospital, or patient with repeated ICU admissions, and patient with a history of dementia and psychiatric disorders, or patient with a cardiogenic shock. As well as here, something to keep in mind, we excluded an end-stage liver disease and neuro patients. We also we kept a record for the eligible non-randomized patients, which defined as patient with a missing consent. An ICU physician or a primary team declined the patient enrollment. Okay, moving to the outcome, visibility outcome. So we use something called progression criteria for the visibility outcome. We define the consent rate for the visibility outcome as the consent rate is adequate if it's more than 70% of the surrogate decision maker or patient choose to participate upon being approached. And we define the successful recruitment if we're gonna recruit more than 3 patients per month. Protocol adherence, we define that as more than 75% of protocolized intervention and assessment of protocol deviation or violation. So what we found is an average patient enrollment for us was 3 to 4 patients per month. The consent rate was adequate. About 89% of the surrogate decision maker or patient choose to participate when we approach them for consent. Recruitment rate decreased a little bit during the COVID pandemic, and we halted actually the trial for 1 month, and then we resumed the recruitment again in a slower rate in March 2020, with an average rate for patient recruitment 1 to 2 patients per month. In total, 12 patients were enrolled outside the traditional hour during the weekends or night shifts, and this process was facilitated with the in-call physicians. Patients were excluded post randomizations. About two of them were excluded after the post the randomization. So we have a retention rate of about 98%. The median hour from consent or enrollment until the ketamine started about 4 hours. And our protocol and adherence was 76%, which just hit the progression criteria we set for adherence rate. And we were able also to improve our adherence by using different strategies like education sessions for the clinical staff and with the clinical reminders for the nurses. This is mainly the visibility criteria was the main primary outcome. Those are the moving to the clinical outcome. This is more of exploratory clinically relevant outcome. As you can see here, majority of them is non-significant. The median duration of mechanical ventilation on day 28 was 7 in ketamine compared to 5 in control group. The ventilator-free days about 19 in both groups, and the median duration of ICU length of stay was comparable also between groups. No serious adverse events were observed in either group. If you look at here, the hemodynamics, with regard to hemodynamics in a change for the change in the heart rate or MAP at baseline of 24 hours or 48 hours, we found also no statistical evidence for difference between the patient randomized to ketamine or control arm. Moving to the sedative requirement and sedation score. So if you look at here, the left side figure, which depict the percentage of patient or adjunct sedative at baseline and 48 hours post-randomization. And there is no difference was noted between the two arms, the ketamine or a standard of care. The table on the right side summarizes the median or the interquartile range for the amount of sedative required in both arms, in baseline and in 48-hour post-randomizations. And again, it was similar between the two arms when expressed in milligram or in milligram per kg. If you look at the RAS score, more patients attained a goal RAS score at 24 and 48 hours in ketamine, about 67% and 73% respectively. Okay, moving to the vasopressor requirements. There was no difference in baseline value of vasopressor pre-randomization, with exceptions of vasopressin, which was a little bit higher in ketamine-treated patients with a median of 39 units compared to the standard of care arm. So in general, this pilot RCT explored the visibility and informed the design of a larger trial, phase 3 RCT, to investigate the ketamine on clinically relevant outcome in ICU. We achieved our threshold for recruitment and concentrate. So with that, we demonstrated the trial is feasible and acceptable to clinicians, families, and patients. We also demonstrated that ketamine have been appeared to be safe and has a positive effect on some surrogate clinical outcome, like the patient achieving the target RAS and pain score. There was no increase in antipsychotic drug use post-randomization, and there was no change in hemodynamics between the ketamine or standard of care arm. And there was we didn't observe any serious adverse effect. So this might be also particularly important during COVID era when medication shortage have necessitated the development of alternative strategy to keep patient on mechanical ventilation comfortable and synchronous. So our pilot study have several strengths. It's included a higher rate of completed follow-up patients with a comprehensive assessment of adverse effects associated with ketamine use and its impact on hemodynamic response. So we believe that our results provide an incremental value in understanding the effect of ketamine. The second thing, we adhere to modified intention to treat principles, randomization, and blinded outcome assessors to limit the potential source of bias. We included also a diverse patient population from medical, surgical, and transplant. And we did every effort to include the patient with a narrow randomization window. So we tried to include the patient within 24 hours of intubation to eliminate any potential confounder with other co-interventions. We also collected some information about the clinical outcome, which might be has an implication on sample size calculation for the main upcoming definitive trials. And also, the other thing is to limit because our pilot study was an open label in design. In order to limit this limitation, the outcome assessors and patient and family were blinded to treatment assignment, and the study investigator also remained blinded to the study result and until the study conclusion. The main limitation for this pilot study, again, it's a small sample size, which is expected because it's a visibility trial. So it's underpowered to detect any difference in clinical outcome or subgroup analysis. We also, with the adherence rate in our trial was 76. However, we considered additional strategy to increase our protocol adherence, which will be used also in our planned definitive trial, like a printed checklist or educational sessions for bedside nurses. So for the future studies or the planned definitive trial, we'll consider mainly capturing the co-intervention and studying the ketamine, probably including more diverse population like COVID patients and neurocritical care patients. So we're gonna plan to modify the inclusion criteria. And this will be discussed shortly after a few slides, as well as we'll plan also to include the end-stage liver disease patients, and to capture also the co-intervention in the definitive trial. So following the pilot study, the systematic review was conducted to synthesize the available evidence regarding the use of ketamine versus non-ketamine regimen for anego-sedation in ICU patients. So basically, this is a systematic review for database included the midline, IMBASE, and the clinical trials.gov, as well as the Cochrane database for systematic review. They performed their search from the inceptions of those databases until November 21st. Using the following search terms: critical care or ketamine, sedation, and analgesia. All the study included here is mainly RCT or the quasi-experimental studies, as well as they included the observational cohort study. They excluded mainly those crossover design or pre and post study designs because of the time-dependent bias or the immortal bias. They extracted mainly the primary or the main outcome, like the opioid sedative consumption, duration of mechanical ventilation, ICU length of stay, level of sedation, adverse events, and the adverse event, including the ICB elevation, incidence of delirium, and all cause of mortality. All the opioids converted to morphine equivalents, as well as the sedatives converted to the midazolam, especially the benzodiazepine, they converted this to midazolam equivalent. So the search yielded about 3,000 potentially relevant citations after removing the duplicates and screening the titles and abstracts, a total of 110 citation reviewed in full and summarized here in the Prisma figure. However, 19 study met the inclusion criteria, about 13 RCT, 6 observation studies, with a sample size of 2,255 participants. This here, the slide summarized the bias assessment of the included RCTs. They used the Cochrane risk of bias to assess for the risk of bias in RCTs, and it was high in 5 of the 13 RCTs. 3 of the studies will lack of the blinding concern there, and there was a concern in missing outcome data, as well as bias in measurement outcome and selection of the reported study. 3 studies assessed as a low risk of bias as overall, and 5 studies noted to have some concern in allocation concealment. The quality assessment for the observation study is not showing here in the slides. However, it's generally been judged as high risk of bias because of the immortal time bias noted. Then moving on to the results or the characteristic of the included RCTs. 3 of the RCTs included, 3 of the studies enrolled a post-operative patients, which you can see here in the blue square. They enrolled a post-operative patient following the major surgery and receiving a morphine PCA. Another study here shown in the orange square, they included the patient on mechanical ventilation and ECMO with a sample size of 20. And the study was weighted only 0.1% in the meta-analysis forest plot. The two study focused on mechanical ventilation patient, which shown here in the square. It's more than 5 studies on mechanical ventilation patient. 1 reported relatively a large reduction in opioid consumptions, and the other increased in opioid consumptions in ketamine group. 3 of the RCTs compared the ketamine in combination with both opioid and sedatives to the same regimen without ketamine in mechanical ventilation patient. And some studies also included the patients with head injury, which shown here in the, or neuro patients in general. I think the neuro patient are in the one in the red square, and the green square is included the patient with the mechanical ventilations. Okay, moving to the characteristic of the included observation study. The sedation regimen in the 6 cohort study will less clear. The patient in the control group received usual care. The subject in the competitor group generally received ketamine as add-on. Some of this trial also included pediatric populations. So they included adults and pediatrics when they pulled out the results together. Moving on to the forest plot. The first forest plot summarized the mean morphine equivalent dose, and the 6 RCT demonstrated a reduced opioid consumptions with the ketamine regimens with a participant total of 494 patients. And this was the mean difference was shown to be significant, 13.1 decrease in morphine, mean equivalent morphine dose in ketamine compared to the standard of care. Looking at the other outcome, no statistical significant difference observed in the sedative consumptions, which is the second forest plot, mean duration of mechanical ventilation, as well as in the mean ICU or hospital length of stay and mortality. With regard also the ICP or the intracranial pressure elevations, there was no difference between the 2 groups for those studies reported on the or included the neuro patients. So the here we're gonna go over the grade assessments. So in general, the study have a very low to low certainty of evidence with a high heterogeneity. Even the one that it showed a significant reduction in opioid consumptions, you can see here the chi-square is 94%. This is because of the heterogeneity of the population included in this meta-analysis, as well as the doses regimen that was used is totally different. Like they pulled the result for patient who, or for the studies that used the ketamine adjunct in patient post-operative while they using the morphine PCA, and they pull it out together with the patients on mechanical ventilation, they using ketamine as sedation. So that introduced a heterogeneity, and that's why we're saying the chi-square here. So in general, there was no statistical significant difference except for the opioid consumptions, which still showed a high heterogeneity. So the author concluded that the small sample size of the study may have limited the ability to detect the true difference between the two groups in the clinically meaningful outcome. And data on ketamine centered outcome and safety are still unclear and uncertain. With regard to the delirium results, the delirium results were inconsistent. So 3 studies showed a decreased incidence, while 1 showed increase in incidence. Other studies generally reported comparable or null psychomimetic effects. So the limitation for the systematic review, as I mentioned, it's a small sample size for each study included, they are having a small sample size, indicating the need for larger and more robust randomized RCT. They also included a heterogeneous nature of ICU population, adults and pediatric, combining also mechanically ventilated patients and non-mechanically ventilated patients with different ketamine dosing regimen and different paired drug combinations. 6 of the RCT relatively having a short follow-up, less than 48 hours. For that, the conclusion from this systematic analysis or systematic review and meta-analysis is a further study are needed to examine the effectiveness of different ketamine dose and infusion rate, and to better understand the impact of ketamine on long-term outcome. So after this systematic review, the plan is to develop a rapid practice guideline based on the available evidence for the use of ketamine. And this is just to understand the balance of effect, resource required, acceptability and visibility, and knowledge gap. Then we'll move on to the proposed international randomized active control multicenter trial, which is the main focus from this presentation. And the key questions actually from this definitive trial that we need to answer is intubated critically ill patients with mechanical ventilation. What is the impact in terms of the efficacy and safety of administering ketamine to usual care? If we're gonna give the ketamine in modified higher dose and longer duration versus the usual care alone on extubation rate or the ventilator-free days, which is the primary outcome that we're planning to, which to be determined yet, and the other patient important outcome. This will be a pragmatic, multi-center, open-label, parallel group superiority randomized control trial with a blinded endpoint assessors, and this will be in collaboration with the Saudi critical care trial groups, or under the umbrella of Saudi critical care trial group. The proposed center to be included mainly is going to be Saudi Arabia, as well as the low, middle, and high income countries, including Kuwait, Emirates, Egypt, Jordan, Canada, Europe, India, and US. The trial will be prospectively registered in clinicaltrial.gov and Saudi FDA, and will follow the concert statement for reporting the clinical trial. The study design will follow the majority of the Spectre key elements in design and conduct of clinical trial in sedation and mechanically ventilated ICU patients. So our hypothesis is we hypothesize that the adjunct ketamine to the usual care for an intubated critically ill patient will improve the extubation rate and increase the ventilator-free days compared to the usual care alone. The study population, we mainly adopted the same inclusion criteria and the exclusion criteria from our pilot study. However, as I mentioned before, we modified the exclusion criteria in order to maximize our generalizability. So we're gonna include the neurocritical care patients and the liver failure patient. It's not anymore listed in the exclusion criteria, but otherwise it's the same adapted inclusion and exclusion criteria from our pilot visibility trial. The study procedures, the control group will receive the standard of care in the ICU, which can include propofol, fentanyl, or dexmedetomidine or midazolam, according to the institution sedation and anesthesia protocol, as clinically appropriate. And our treatment or the intervention period was going to be for 14 days after enrollment. The intervention group is after the patient is intubated and until we get the consent from the patient will stay in the usual group until we get the consent. Then the patient will be, if the patient will randomized, if the patient will be randomized to ketamine, we'll start the ketamine at small rate, then we'll titrate up to achieve the target sedation goal that's set by the ICU physician according to the RAS score. So let's look at this figure, maybe summarize the study procedure in a better way. This is mainly here for the intervention arm. So once the patient met the inclusion criteria and intubated, he will start or she will start on the usual care analgesia. Then once the consent is obtained and the patient is randomized to ketamine, we'll mainly start the infusion in 0.8 up to 5 mics per kg per minute with a goal to reduce the fentanyl boluses or infusion above. Then we'll adjust the rate of ketamine according to the RAS score. So if the patient is deeply sedated, the first thing we recommend in the protocol is to decrease the fentanyl infusion or other rescue sedations to minimum effective dose or discontinue it. If the patient remain deeply sedated still, then at this point, we recommend to titrate the ketamine infusion to the lowest effective dose. On the other hand, if the patient is under-sedated or the RAS is more than 2, the ketamine is titrated up to the maximum rate, and we set the maximum rate here of 15 mics per kg per minute. If the patient is still under-sedated after that, then the protocol allows to use a rescue sedations, like to optimize the fentanyl analgesia or to start propofol boluses or infusion, or add the dexmedetomidine or midazolam intermittent boluses. So we're gonna continue this or the intervention period up to 14 days or until the patient is extubated, death, whatever comes first. The consenting model we're gonna use is a mixed model, which is a priori and deferred consent, written or witnessed oral consent, which is according to the local standards or the approvals for each country. The randomization of eligible patient will be 1-to-1 ratio in variable blocks, 2 to 4 and 6 blocks, and we're gonna use a concealed central computer generated randomization procedure using a REDCap software. The stratifications of the randomization will be done according to the trial sites, as well as presence or absence of proven sepsis or suspected sepsis. For the allocation concealment, the concealment of the randomization will be ensured at each arm through a remote dedicated online randomization system. And also the researcher and clinician and bedside nurses, patient and families will be blinded, and the group allocation will be concealed until after randomization. The study personnel will also remain blinded to the study results or the interim analysis results until the enrollment is completed and database is locked. The treatment group assignments would be concealed from the member of the Data and Safety Monitoring Committee and trial statistician as well. Post-randomization, blinding of the study arm, it's an open label design, so it's the post-randomization, the blinding of the study arm aren't possible for the following reason. So we think that in order to make it more pragmatic trial design, an open label might be appropriate to maximize the generalizability. And also that the outcome that we are concerned of, like a ventilator, 3 days mortality, readiness of extubation, ICU, and vasopressor-free days. This is all our objective outcome and not subjective outcome. So it's unlikely to be influenced by unblinding. So the primary outcome is something to be discussed after the presentation as well. Either we are planning to use the rate of successful extubation up to day 28 of randomizations, or the invasive mechanical ventilation ventilator-free days up to day 28 of randomizations. And the rationale we're using this primary outcome is the biological plausibility of ketamine in lowering the airway resistance and preserving pharyngeal and laryngeal protective reflexes and increasing the lung compliance without causing any respiratory depression. So our hypothesis that ketamine might have a bronchodilatory effect because of the anticholinergic effect, which might have an advantages in terms of fasten the extubation and prolong the ventilator-free days. For the secondary outcome, we're going to look at the main secondary outcome similar to other sedation trials, delirium or coma-free days at day 14 and 28 of randomization, proportion of patient achieving sedation and pain score goals during the intervention up to 14 days of randomization, and the time spent at target sedation and pain score goal, as well as the cumulative dose of pain and sedatives. With other safety outcomes. So the look at safety outcome up to 14 days of randomizations, such as rate of unplanned extubation, the use of antipsychotics, physical restraint, and re-intubation, the ICU-free days at day 28, vasopressor-free days at day 28, day alive without sedation, as well as the all cause of mortality up to 60 days of randomizations. Moving to the sample size and power and analytical plan. So if we plan to use the extubation rate, which is a binary outcome, as a primary outcome, so we based actually our sample size calculation based on the previous literature as well as the pilot study results we had, which showed a rate of 60% liberation from mechanical ventilation within 28 days post-intubation. So if we're assuming the extubation rate is 60 in ICU patients with mild to moderate ARDS, treated with a standard of therapy. And if we look at the power of 90% study power to show an absolute difference of 15% in extubation rate, then we need a sample size of 426, accounting for 5% follow-up. So each arm will have 213. If we're looking at the ventilator-free days as our primary outcome, which is a continuous outcome, again, looking at our pilot study as well as the previous literature, usually the ventilator-free days 14 as a mean, with a standard deviation of 18 days in ICU patient with mild to moderate ARDS. If we selected the power here is 80% power to show a mean difference of 4 days in primary outcome between the two arms with a two-sided alpha of 0.05, then a sample size increased here to 600, about 600 total, which is 300 in each arm. Okay, for the plan for the statistical analysis, we're planning actually to do the frequentist data analysis as well as Bayesian approach would be considered as additional analysis. We're going to follow the intention to treat principle, and the listed here in the slide is the plan for the subgroup analysis. We're gonna do for a subgroup analysis based on the severity of hypoxemia, stratified by the PF ratio, ventilator mode, the age more than 65 or less than 65, the sex or SOFA and Apache score higher or lower than the median, or the ICU admission type, presence or suspected sepsis, and timing for initiation of ketamine, the dose of ketamine higher or lower than the median, and the duration of ketamine higher or lower than the median, as well as the high income country versus the low or middle income country. The study is planning to have a data safety monitoring committee, which we plan to do an interim analysis when we hit the 50% of the sample size. We haven't determined which rule or which stopping rule we're going to use, but generally either we're going to use a modified Pero boundary stopping rule or the O'Brien-Fleming methods. Regarding the data collection, so we're going to collect the data for the baseline outcome or the demographic for the patients, and as well as the daily ICU data, which will include the ventilator mode, the sedation score, the pain score, what sedative the patient has been on in day 1, 3, 5, 7, and 14. Then up to, we're gonna collect the outcome form at day 14, 28, and 60. Then also we're gonna collect the protocol violation, deviation, serious adverse event, and withdrawal of consent by family. Here the following suggested site to be included for the trial, and the sign-up form in red cap will be considered for recruiting the sites. And depending on the participating site, we anticipate to complete the recruitment within 2 years or sooner. So what is this study is important, or the knowledge translation, what we're gonna get from this study. First, this definitive trial is important to guide the clinician in consideration and dosing of ketamine for multimodal analgesia. Usually ketamine is inexpensive medication compared to other sedatives, and if proven to be effective in patient-centered outcome, this intervention could be widely adapted in low-income countries. The second thing, this RCT will also be incorporated in the rapid practice guideline when planned to do an update for it. And also we are planning to do a sub-study from this definitive trial. The sub-study nested translation biology studies, health economics, and precision medicine or pharmacogenomic, as well as looking for the long-term outcome at 90 days, the health-related quality of life, and the health survey, the 36-item short form health survey and questionnaire. So that's it, and I'm happy to take any question.
Excellent. Thank you, Dr. Amaro, for this outstanding proposal and protocol. Fantastic to see this coming along. We'll open the floor for questions. If you have a question, please raise your hand, and we'll and then unmute yourself. So I guess I'll start with the question. I think one of the major concerns with ketamine is the delirium. And I think I'm not sure I missed it or not. Should be one of the main outcomes of the study. Should have some safety outcomes. So
Yeah,
can we
absolutely.
go back to
It's
the
going
outcomes list?
The secondary outcome, delirium or coma-free days.
Yeah, the first one.
Mhm.
Yeah. Do you think they should be separated? Delirium and delirium, I think, should stand alone. I don't know.
Let me see it how it's, because this outcome I took it from the previous sedation studies. Let me see how they expressed it. Is it two separate outcome or they combine it together?
Okay, fair enough.
Mhm.
Questions from the group. So there are a few suggestions from myself you may want to consider. First of all, in terms of terminology, if you can go previous slide, it's minor point about about concealment and blinding. Yeah, so concealment is before randomization. Blinding is whatever after randomization. So concealment, I think the first statement is correct. Researcher will be blinded, that's correct. Remain, where it says researcher, clinician, bedside nurses will be blinded and group allocation will be concealed until after randomization, that's correct. Yeah, but this third sentence, treatment group assignment will be concealed from members of DSMB and trial statisticians. There are two issues. One is the data safety monitoring board have to have access to the data. So you cannot blind them. So they have reports that will be blinded, but if they see something, they will need to see the allocation. They have to be unblinded. That's number one. And the trial statistician, will be DSMB by statistician who is unblinded. And then the word concealed here is not correct. It's blind, should be blinding. But anyway, the blinding for DSMB is really not a complete blinding. They should have access to the data. They will get open and closed report. And so if they say safety issue, they need to know which group is which. That's important. Otherwise, they cannot make decision. Next slide, the outcomes, secondary outcomes. Generally speaking, it's better not to have a lot of outcomes because then you have to adjust for multiple testing and reduce your power a lot. So for example, do you need delirium and coma-free days at 14 and 28 days? They're going to be very similar. I mean, just choose one of them. That's my suggestion. Some of these listed outcomes are really not outcomes. They are kind of process measures, like the dose of analgesic sedatives. I think that can be in table 2, this information. So it doesn't count on you to be outcome. So stick with the outcomes that are essential. The other thing I noted that you have different multiple time follow-ups, like all-cause mortality at day 60, and then you do quality of life at day 90. Better to stick with one.
Okay.
Because this day 60 or 90 means phone follow-up. Many patients will be left the hospital. So to call them at day 60 and day 90, just way too much.
All right.
And then the quality of life should be an outcome. Is it not an outcome?
It's one of the sub-studies. It's going to be reported separately. So long-term outcome at 90 days, the health-related quality of life. So it's one of the sub-study to be generated.
Yeah, but should be a registered outcome.
Okay.
Should be an outcome. It's a clinical outcome.
All right.
The other thing, the subgroups, if we can go to the subgroups. So subgroups by definition have to be based on a baseline variable. They cannot be based on a post-randomization variable. So for example, they cannot be based on timing of ketamine initiation or higher dose or lower than this. You could do this exploratory tests, but they are really not. They don't meet the ideal subgroup outcomes. Duration of ketamine higher more than median, because I mean the duration of use is based on the intervention. It's really dependent on the outcome. So these ones, not sure. The other
So
thing,
8, 9, and 10, right?
8, 9, 10 should be out.
Mhm.
Ventilator mode, do you think that will affect the? I think you should select the subgroups that you think they will behave
Might have
differently
a
with the
rationale.
intervention.
Mhm.
So for example, do you think the ventilation mode, if I put patient on pressure control versus volume control, ketamine, these will respond differently to ketamine? I doubt. I don't think so. But on the other hand, I would think, for example, patients with renal failure, because if you spare people from fentanyl accumulate a lot in renal failure, and I don't know about ketamine. Maybe that's an advantage. Maybe, I don't know. So I think should select out subgroups that potentially would respond differently to the intervention. So sex, I don't know. Do males respond differently to ketamine than females? If there is biological reason, yes. If there's no, would not include it. And many now studies try to make subgroups, not a lot. Again, because you have to adjust for multiple testing. So no need for SOFA and Apache. Just check one.
Okay.
Surgical versus medical, I think reasonable. Maybe versus trauma should be. Sepsis, I think reasonable because you're doing stratifying by sepsis. This is very reasonable. The severity is reasonable. The age is reasonable. Hypoxemia, yeah, yes. As I said, 8, 9, and 10 would not meet the criteria for subgroups. I would remove one of the Apache. Sex, unless you have a reason for males responding different than females, then don't include it. Ventilator mode, I don't think so. I think if, do you think there are some patients more likely to benefit or to be hurt by ketamine?
No, it's more of a hypothesis thing. Like the younger patient might have a larger treatment effect.
Yes.
We have.
How about patient with neuro disease? Because you mentioned neuro. Do you think
we can add this as a subgroup analysis if you think.
Yeah, that's what I'm saying. I think you should select subgroups based on biological plausibility. So in your presentation, you suggested that neuro patients may behave differently. Maybe patient with shock. I don't know. The one that, the effect, what's the advantage of using ketamine? What's the disadvantage of using ketamine? Which patient likely to benefit more from ketamine? Maybe patient with shock would benefit more. Maybe not.
Like,
yeah, possible.
Yeah.
Maybe. Neuro patients are higher risk of delirium, maybe. So I think you should have hypotheses that you mentioned here. Like I like this. So try to focus this approach. What's fantastic work, really amazing. Any comments from the group? Did you do surveys? Or I saw that in your program you mentioned you want to do feasibility survey.
Let me share the already been done the survey. However, we're gonna collect the visibility and acceptability through doing the rapid practice guideline.
Okay.
So the survey was done already. This is the one. It's mainly for the SCCM.
But no, that's not what I meant. Did you do survey in Saudi Arabia? Because this is where you are doing the study to see the acceptability of people, their interest in the trial. You may want to consider doing it
Sure.
in the countries where you are hoping to do the trial, other than the SCCM. You could use some of the questions or the files they have, but what's the percentage of people will be interested in doing randomized control trial on ketamine? What centers have ketamine, for example? So 70% of respondents says that we have ketamine. 70 or 20, whatever percent, they said in Saudi Arabia, they said we use ketamine in ICU or never use ketamine in ICU or whatever. So I think it will help having a picture of in your sites where to go and how many people interested in randomized control trial. How many of the people respondents have done an RCT ever? Okay.
Okay.
So some RCT questions. Do you have research coordinator? All right, I don't know, you have to think about this, but feasibility for your trial.
Okay.
What else in the program? Feasibility trial you've done, survey done. You also the systematic review is done by some other group. I don't know if it's worth repeating or not. You did this.
We're gonna do an update. We're gonna do an update in it once we reach to the rapid practice guideline.
Yeah, okay. Yeah. Okay, good. Questions from the group? You could raise hand if you have question. Do you have questions for us, Dr. Amara?
لا really ما في I don't have any question but I can if any of the group having any question raise your hand or unmute yourself. Yani, just to have a sense of how many person would be interested to participate in this RCT by raising hand.
So we have a few hands.
Okay, for those who didn't raise their hands, could you tell us what would be a potential barriers in your site to conduct an RCT?
I think this is exactly what you should do in the survey. This is what you need to do, the survey. So it will give you an idea of how people perceive this question.
Okay, so
and make it short so people respond. You need good number of respondents. So key questions. This is I think these are really good questions you ask. If you are not interested, why not? Is it because the question is not good, or because you don't have ketamine, or because you never done trial, or you think the ketamine is rarely used, or you think you're worried about side effects, or what is it?
Okay. So I think the expectation for next thing will be, as Dr. Yassin mentioned, we'll do a survey to test the visibility of the recruiting sites, how many person interested and how many, what would be the potential barrier for it.
Yeah. Very good. Okay, Dr. Marwa, this is really fantastic proposal, amazing work. Really appreciate your putting this together, really high scholar work. So much appreciated, and looking forward to your next step in this important trial.
Inshallah, and it's my honor, Dr. Yassin, to present today in Saudi Critical Care Trial Meeting Group meeting. Thank you so much.
All the best. Thank you.
Thank
كل
you.
عام وانتم بخير جميعا. Thank you.
وأنتم بخير.